Okay. Welcome everybody from Portland, Oregon. My name is Gray Campbell and I am from 6 Degrees Health. We started this series, the Fireside Chat series back in 2020 because we wanted to elevate the discussion about healthcare insurance specifically. Who are we at 6 Degrees Health? We're a technology-enabled cost containment solutions company for all kinds of different employers who want to keep their costs down. I'm joined by our Chief Growth Officer, Mr. Heath Potter. Hello, Heath.
Hey, everybody. See ya.
Welcome to the episode, Heath. Today we have Dave Chase and Adam Berkowitz on the episode. We are so stoked to have them. I've been able to hang out with Dave a couple of different times, or we have, and now we're bringing in Adam. They're both well-versed in the health benefits space and have all kinds of great insights to share today. So our title is The Journey from Serving Big Carriers' Needs to Serving One's Community, and then actually transforming healthcare how we see it today. If you've got some Q&As, folks, I really want you to use the Q&A function. Heath is going to monitor that, and you can ask any kind of question to these two guys you want to, as long as it's clean. And Heath will push those out in the second half of our show. We're going to spend about 30 minutes getting started today. Talking with Adam about a specific case study he brought to us. So let's get going.
Well, I want to say, you can ask any question, doesn't mean I'm going to read it. So, let's keep it on target here, guys.
Stay on target, folks. We've got Dave Chase here today. He's been here a couple of different times. We really love having you, Dave. Welcome back. I've read your book, Relocalizing Healthcare. The future of healthcare is local, open, and independent. And frankly, I love this book. For those who haven't, I urge you to take a look. We're going to send a link out afterward, and there'll be a link on the slideshow as well, so you can find that. And what I like about Dave's message is just this. Dave urges us to take back control over our healthcare community, one employer health plan at a time. And you can go back and you can hear about that from Dave. He outlines concrete steps. Put simply, public and private sector employers and unions can act now and stop enabling the status quo from ripping us off. In fact, we're going to take a look at a case study today from Adam that does just that. It puts the employer plan firmly in place to decide how they want to take care of their plan members. Hi, Dave. Welcome.
Hey, glad to be on again. Yeah, looking forward to our chat.
Absolutely. And then our second guest, we are introducing Adam Berkowitz today. Adam, I'm so glad to have you. It's really fun chatting with you. We spent the last 15 minutes catching up. Adam is calling in from the Midwest. He's calling in from
St. Louis.
St. Louis, a town I have not yet to visit, but pretty damn excited to hear Adam's stories. He started SimparaHR in 2016. And if you do happen to jump over to his website, you'll see a mission statement. I love this mission statement, Adam. Hardworking Americans deserve access to high quality and affordable healthcare. Can we make that happen? I can get behind this, that's for sure. From my perspective, I have working class roots, and I do believe there's ways for working class Americans to get the healthcare they deserve and actually pay for it. You've got me sold. Adam specifically advises employers and helps find the best opportunities to match their unique situations and needs. The modern health insurance world is complex. I'm certainly realizing that. I've been here a couple of years now, and I can tell you that I can sleep at night, Adam, knowing that people like you are fighting a good fight. Welcome, Adam Berkowitz.
Thank you. Thanks for having me.
Absolutely. All right, folks, let's get to the topic. I'm going to go ahead and read it one more time. The journey from serving big carriers' needs to serving one's community and transforming healthcare. I want to hear from both of you as we get started. Tell me about your journey. We can start with Dave, from serving big insurance carriers to serving your community. How and why did you make this transition? Dave?
Well, I'll share a link with the organizers that you can share it if you want, that I kind of go into the details of a personal story with a friend of mine that basically died to due to a complete system failure. And that combined with this big aha moment, March 9th, 2016, when I woke up and there was the news of Bernie and Trump winning the Michigan primary. And as I unpacked that and realized that the working and middle class had been in a economic depression more than twice as long as our Great Depression or 1930s Germany, it just gave a sense of how bad things were. And that sort of was the inspiration on the first chapter in my first book. We've gone to war for less than what healthcare has done to America, which is a sad statement given we throw so much money and so much amazing talent at it. And basically, after a lot of reflection and study, I came to understand three things that most people don't understand. Healthcare is fixed/fixable. Healthcare is not expensive. And we're already investing more than enough money to not only fund a world-class healthcare system, but to fund or restore funding to what drives 80% of health outcomes, which is not the sick care system. So, the task was really, how do we transition from a system that's really about Wall Street, it's toxic and it's unsustainable, to one that's local, organic, and sustainable. So we can talk more about that.
Awesome. Actually, Dave and I spent quite a bit of time talking about this in some of our earlier chats. If anybody wants to go back to them and take a look, we do have those listed on our website. But thank you so much, Dave. Really appreciate that. Let's move on to our new guest. Same question for you, Adam. How did you get from serving those big carriers to serving your community?
As Dave mentions, the failures of our healthcare system, and I can remember this date quite well. We started SimparaHR about 6 years ago, and it was July 30th, 2016, when my wife and I welcomed our first son into the world. And so we're in the hospital, schedule induction. We're waiting for that show to start, and I get laid off. Talk about an emotional roller coaster of kind of riding the adrenaline of welcoming our first child to the financial safety net kind of falling out from beneath us. But looking back, that was probably the best thing that could have happened. I've been brokering corporate health benefits my entire career, so nearly a decade prior to this. And I was really good at selling insurance carrier plans, really good at spreadsheeting. I'd studied medical trend, looking at national benchmarking data. I had the story down. And the goal was to get our clients to renew as quickly as we could at that low double digits, like 12% increase was really good, so we thought. But that the birth of my son was an emotional moment, and it ties into what Dave said. I mean, we experienced a broken healthcare system, and my wife suffered incredible physical trauma with the delivery, which looking back led to a lot of postpartum depression. And I was holding up the family for about 3 months, not as a chore, as what we had to do, went into survival mode to take care of everything. And we didn't know what we were going through at the time because we didn't know it was unusual. We didn't know what to expect. Nobody told us what to expect postpartum. 2 days after the delivery, they wheel you out of the hospital. But it was about a specialist visit 3 months or so later, and the doctor told us this never should have happened. It could have all been avoided. And so, having that experience and figuring out what was important to us and figuring out what we had to do, that was a pivotal moment. And so we started this business, and I was also reading this really obscure website. Dave, you'll like this. It was a black and white website with a bunch of essays called Rosetta. And it was so esoteric, and it just blew my mind. It was like this underground movement of people that were already fixing healthcare, right. Doctors, advisors. I think the website still exists, by the way. And this was the beginning of Health Rosetta, although I didn't know it at the time. And it kind of led into this, I call this serendipitous intersection of career change, mission path, and meeting Dave, Sean, and his team, and kind of going down this journey. So, the idea that healthcare is already fixed, we just have to scale it, it just resonates. And going through something so personal like that, it's really been the foundation of what we're doing. So it's exciting.
Yeah, I mean, looking at 2016, that's a watershed year for both of you. I didn't realize it until just now that both of you had these aha moments for different reasons, of course, in 2016, recognizing that our system can be fixed. We just need to start doing it. So let's get into a case study, specifically, Adam, that you brought to us. And this is great. I love looking at this case study. It's a testimonial. We'll start there. So in this next slide, the testimonial does kind of showcase, hey, what is this employer getting here? And I'm just going to read this out loud. If I can just move my chat box. First of all, thanks to all of you for all of the work you have put in to allow us to have this level of success with our conversion to the self-funded plan. The outcome, both operationally and financially, has been better than I could have possibly imagined. So I look at this CFO, Mike, and I wonder, what was he thinking before he went to self-funded? And I do recognize that people get a little nervous. You know, when you're with a fully funded plan, everything's taken care of. I mean, it's expensive, but at least you don't have to worry about it. What are these nervous challenges, Adam, Dave, that folks are talking about? Before we start talking specifically about this case study, I want to just have you address these for me, please.
Sure. Well, I want to point out that this was an email received right at the end of our first year with Schaefer Auto Body. So Mike's now experienced what we promised would happen, awesome. Which was almost $1 million in savings. We're going to talk about that a little bit more. But another client of us, not related to this case study, he gave us really interesting feedback, which he said, we trusted you guys to take us down this path and essentially jump off this cliff. We hoped it would happen, all the things you told us, but we didn't know if it would happen. We trusted you. And I think that there's a lot of that packed into this, which is, it's more than just self-funding. We're talking about moving away from big logos, on your insurance card. We're talking about direct contracting with local hospitals and doctors. It's a paradigm change. And so there is a lot of trust built up in that, because we're taking care of their people. And can you think of anything more personal and important than that? So I think that all of those emotions are packed into this quote right here.
Right. Well, let's get into it. Dave, did you want to add anything before we move to the next slide?
Yeah, I will. I'll confess, I think you're playing into the hands of the status quo when you call something fully insured or fully covered or whatever. I don't agree with that, in that if you look at healthcare, it is the #1 driver of inflation, poverty, and bankruptcy. 70%, without question, medical bills are by far the #1 cause of bankruptcy in this country. We're the undisputed world leaders. Wow. 70% of those people had quote unquote insurance.
Brutal.
I don't think you can call that insurance. That is not a fully funded insurance program. And so you can have a carrier controlled plan that might be marketed as fully insured, but the evidence is tens of millions of people are functionally uninsured because their life savings are less than their out-of-pocket responsibility. So that's one of the things we have to I didn't know anything about health plans, 6-10 years ago, right? I was in the health IT arena. It was only when I dug in and understood what was going on here that these things became self-evident if you dug in. The kind of related point is sometimes people will call somebody like Adam or me a disruptor. I'm like, no. We're a restorer. We're restoring sanity. We're restoring the American dream. What's disruptive is what I just talked about. What's disruptive is our status quo health plans are funding medical mistakes, preventable medical mistakes being the 3rd leading cause of death, and what has funded the first 20 years of the opioid crisis. That's disruptive. And so we have to be honest with where we're at. I don't like to spend much time on the status quo because where we're going is so much better, and I'd much rather talk about that, but we need to be honest up front before we get into that.
I do remember, Dave, you talking about the carrier model and using that term instead of the fully funded. So thanks for reminding us and introducing that to the audience today. Appreciate that. Let's bump over to the next slide and we'll talk specifically. Adam, you will talk specifically here. I'm going to ask you a question. So this is the case study. It's from Schaefer Auto Body Centers, and they have had a carrier style model back in 2020, and they transitioned to a self-funded model in 2021. You can see the significant cost savings here, and you'll talk about them. And from this perspective, it's a huge benefit for the employees, okay? Those workers. I see a huge benefit. I mean, I'm looking at this right now, seriously, no deductible, no co-insurance, $1 generic drugs. How the heck does this plan function? Tell me about it.
No, I think this is really representative of the culmination of a lot of work, and also learning from the vast community that Dave has shepherded, in this industry. And so this isn't, singular, like look what Adam did. There's a lot of hands that went into making this possible. Schaefer Auto Body has about 250 employees, 16 or so locations. It's a second generation family owned business. It's very prominent in St. Louis. And the plan they had before, I just picked the one in the middle because they had 8 different plan options that they offered their employees, different deductible ranges, 2 different networks you can choose from. I mean, just dizzying number of options. And it was all from just okay to even worse, right? There wasn't like, oh, I want the best one. There wasn't a great plan option. Costs were approaching almost $2 million. And I'll never forget the cover letter that we got supplied when we were digging into their data. There was one medication that was costing the plan $500,000. And the cover page indicated that the drug was being procured by the specialty pharmacy, which is owned by the insurance company. And it was like, we're managing this. You're getting the drug through our specialty pharmacy. That's the best place to get it. No need to go anywhere else. In fact, you can't go anywhere else contractually. And if you can take that idea and apply that to anything else in business, what singular line item would you not shop out to that magnitude, or at least research to see if that was the right price, the fair price? It's mind-blowing. And so we transitioned their plan to something that I think is quite human, right? No deductible, no co-insurance. It's, by the way, one plan for everybody. So this is the option. So everybody went from whatever they had, $3,000, $2,000 deductible, $5,000 deductible, to this option. Generic drugs are $1. Mental health is free. I mean, this is really easy, right? Most people don't know what co-insurance means, but this is free healthcare. And if you look at, average wage, maybe $50,000, and if somebody has to pay a $5,000 out of pocket, if they're after tax take home pay, that's like 12-15% of their after tax take home pay just to pay their deductible. It's right for what Dave is saying about being functionally uninsured, having a product that really doesn't provide you any financial protection. And that's before calculating what employees are paying in premium. So complete transformation in just a year for every employee of Schaefer Auto Body. It's really incredible.
It's insane. And I know we're going to go on to the next slide in a moment, but while we're here, I do want to ask, somebody just popped into the chat. Folks, make sure you're asking questions through Q&A. Heath's moderating those, but I do want to just ask you real quick, Adam, is there a network tied to this?
Yes and no, not in the traditional sense. Actually, this case study is also a 6 Degrees Health case study. Oh, perfect. I did that on purpose. You're welcome. We're doing a lot of direct contracting. So St. Louis, the bi-state area between Missouri and Illinois, we're very fortunate to have really great healthcare options here. But we're primarily, we're dominated by 3 major health systems. And so we started partnering individually with these systems to provide transparent and fair pricing, which drives down unit cost of care. We already have great quality healthcare in this area, so that wasn't an issue. So we're looking at directly contracting with one of the largest health systems in our region across the state. to get to no deductible, no coinsurance. So there is a second tier that I'm not showing here of the plan that has a $1,500 deductible or so, and that's if you went outside of this direct contract.
Okay.
But it's such a vast network. I use that word, probably shouldn't, but it's such a vast health system. I would say 70% of our claims are going into that hospital system and that healthcare system. So it's working really well.
Well, thanks for the plug, Adam.
Mm-hmm.
I appreciate that. Let's move to the next slide and let's actually get to the employer's perspective here. This is the financial stuff that usually my brain starts to explode when I see these things. And I just want to say, for example, RX means prescription, PEPY, per employee per year. So as you're describing this, try to give us layman's terms, Adam, for folks who are newer to the industry.
Sure. So, first thing is we start getting data, right? That's, I say the beauty of being in a model like this is the transparency and the control and the ownership you have over this investment. And it's a sizable investment, where you're not getting this type of insight or control previously. The cost savings is really just the icing on the cake. Because providing great healthcare in a transparent manner, you're going to bend the cost curve down. So that's the trust factor, that's actually a true statement. But what we're seeing here is a year in, start at the far left, the RX, your pharmacy spend per member per month. We didn't have their plan data, so we're benchmarking against the national average. I think this is according to Kaiser. It's about 50% less than your national average. It's a really good metric because what this does is it takes your prescription spend down to the member level, so you can really track it over time. PEPY is total spend, so per employee per year. And what we're looking at is all costs involved: claims expenses, your fixed costs like administrative fees, stop loss premiums, our fees are included in here. We want this to be a very fair picture of everything they're spending on healthcare. And with, I think, 170 on the health plan, this is where we get to about $900,000 in savings. So about $5,000 per employee saved per year, just in the first year. Loss ratio, I think, is a very common metric. We're looking at claims out versus dollars budgeted. So 44 cents on the dollar is what was actually spent versus the budget. And then on the far right, the premium. So going into year two, because we optimized the plan so well, and because it performed so well, you actually see your fixed cost premium go down in year two. How often do you get to deliver that type of news to an employer and employees that everyone's cost is going down? So, we talk a lot about how in this model, we're all in this together, employees and employer. We have to make smart healthcare decisions to enable this type of performance. And this is just a testament to that work.
Yeah, no, it's incredible. And I definitely want to hear from Dave on this stuff too. When it comes to plan design, you already mentioned, Adam, that it's complex. It's not just you waving a magic wand and making things better, but there's a lot of different partners that come in here and affect this and create a plan design and create change. Dave, what are your thoughts on this stuff?
Well, I'd bring up a couple things that people don't typically think of or necessarily believe, but is actually true. One of which I mentioned earlier. I said healthcare is not expensive. What I mean by that is the clinicians only get 27 cents of every dollar ostensibly spent on healthcare. Most of us think that's what healthcare is. What's expensive is profiteering, price gouging, administrative bloat, fraud, and inappropriate care. And so if you choose to not pay for those things or minimize them, then you can achieve what Adam and his client have achieved. The other thing that people often are surprised to hear, and I had a chapter in my first book on this, in the real market, prices are flat in healthcare, the exception being specialty drugs. And when I say the real market, it's direct contracts, it's cash pay. These aren't little fringe things. There's large amounts, particularly in the era of high deductibles, of cash pay and direct contracts. In those markets, prices have essentially been flat for some time. And that's how you achieve, what the subtitle of my first book was How to Deliver World-Class Healthcare to Your Employees at Half the Cost. That was somewhat aspirational when I wrote that 5 years ago. I mean, I did have case studies of folks who did that, but I had to scrounge, frankly, pretty hard around the country to find the employers who'd done that. Now I have a good problem that there's too many success stories to actually put into some update on that book. So that's there for the taking. And going back to the earlier question, I think in the Hall of Fame of marketing achievements is many perceive PPOs as something that would give you a discount you couldn't get on your own. And that may have been true at one time, but actually the opposite is true. I wrote a piece that, again, if you want to share afterwards or in the chat, feel free, that I'm sharing with 6 Degrees, that, basically asks, have PPOs perpetrated the greatest heist in American history? Spoiler alert, yes. And so you don't need to wildly overpay for the privilege of wildly overpaying on healthcare. There are great hospitals, great surgery centers who are willing to happily cut out middlemen. Adam's showing that. We have many examples of that. Obviously, 6 Degrees is very familiar with that.
Nice. Let me ask about the stop loss piece, because this is something I find fascinating in how stop loss, because from what I understand, it's a huge expense for these plans outside of the actual healthcare spend. They're spending a lot of money on this sort of secondary insurance. What can you folks say about that? You and Dave, Dave and Adam, what can you tell us about these stop loss premium savings, 12% in 1 year? That's pretty steep.
I think something we've learned, going down this journey, and certainly tinkering in our fair share of setbacks and plans that didn't work as well as this one, quite honestly.
Okay.
We start realizing that stop loss can be treated like a commodity, or you can view this as a critical component and partner to the plan, right?
Yes.
So we started really investing deep in relationships, on this side of the risk management spectrum, which is stop loss, and saying, what do we need to be doing to collectively manage the risk of this plan, and how can we get creative on keeping that cost as low as possible, frankly, right? Because once the employer realizes kind of the difference between soft dollars, the claims, and they get to keep the upside, and the hard dollars, which are your stop loss premium, they say, how can we get our stop loss as low as possible, right? So a plan of this size, it's probably 15% of their total spend. So it's making those partnerships and having those conversations, and when big claims come up, we're calling our stop loss partners, and we're talking through them and seeing if there's anything that we can creatively come up with to achieve better outcomes for the patient that are going to reduce costs in the long run. So it's really having that open phone line to do this, because it takes all parts, right? If we're like the general contractor here and putting all these things together, but each partner plays such a critical role, and then making them work together is the magic. So.
No, I love that. It's just fascinating to me when you think about, how much savings you can get from these folks. And we actually discussed this in one of our previous fireside chats. We talked about, the fact that, these stop loss carriers, if you reach out and let them know, hey, it's coming down the line, we've got some issues happening, let's talk about it. It's back to that partnership piece, treating these folks as a partner, as opposed to, I think you said commodity, Adam, which I appreciate.
Yeah, unfortunately, I think because the volume of RFPs and quotes that go out every single day to these companies, that they're just responding, right? They're like, you asked for this type of quote, this is what you're going to get. But we found that having that dialogue and having that conversation, you start blending, expertise, and you start getting results like this, that, it's not just everyone gets the same quote or everyone gets the same price. We're being really strategic about how we do this.
I see a really great stop loss conversation in one of our future fireside chats. I think Heath and we should get together and talk about that. But thank you, Adam. Dave, do you want to add anything before we move to the components here, the bullet?
Yeah, I think a frame of reference is helpful here. When you enter the healthcare system, you're not at your best. You're basically in a health hurricane, and it's challenging, right? And in a regular hurricane, you're not allowed to price gouge when somebody is in that extreme situation. Unfortunately, we've allowed that. And if you look at the folks who insure against things like hurricanes, when there's a hurricane, that's when you'll see in their earnings that they've had a terrible year, right? Because they had to pay out a bunch of claims. When we've had sort of the ultimate hurricane in our healthcare system, the pandemic, because of our upside down system, the carriers have had record earnings. And so really they are not the carriers of risk. The folks who carry the risk is the employee, we already talked about, the employer, and the stop loss. They are the real insurers. And Adam spoke beautifully to the partnership. And with Adam and his colleagues in our community that have put in these types of programs that actually manage the risk, the stop loss carriers understand that, and then they give relief. And it is this kind of partnership arrangement. So I think it's important to recognize, right, most of what we pay for in healthcare are budgetable. You know, over a certain number of lives, you're going to have a certain number of knee procedures and physicals and MRIs and whatever. That's budgetable. And we've confused, true insurable events from budgetable events. And that's one of the things that Adam and folks like him understand, and then can help explain that with employers.
Right. And you make a good point, because the stop loss is not health insurance, right? I think that we conflate these things.
Okay.
The employer is funding these, and it's really employee money when we think about it. This is all part of total compensation. And so stop loss is just a risk protection and capture mechanism. That's it. So we have to look at managing the risk, which is the claim side. Stop loss just is there to back us up.
Well, let's get to those components on the next slide, and we'll kind of go through these. And I just really want to throw this out there for you, Adam and Dave. Please just either interrupt Adam or jump in. I want to go through these one by one if we need to. Leave the system, shop local. I know that's a big thing for you, Dave. Eliminate deductibles, first-class advocacy, constant iteration, and then the broker alignment. So however you want to tackle this, Adam, let's talk about why you included this in the slideshow today.
Yeah, well, first I'll mention that I stole and ripped this from Dave and his local acrostic, but that's trademark, so I couldn't use it. But it follows that paradigm that Dave and his team have set forth, which is really the key to unlocking this. And it's not that every company needs to do all of these things, and there's more than just listed here. Primary care is not on here, but this really gets to this specific case study. So when we're talking about leaving the system, I'm talking about leaving behind all the waste and the way that insurance has typically been insured and how we buy insurance in the traditional sense, right? Talk about the spreadsheeting and looking at the same 4 companies every single year. So we have to get away from that, because we need to own the plan. We need the control and the flexibility that allows for everything else to follow. And so it's really realigning all of the interests to work together towards the common goal, which is healthcare can be affordable and you can have a wonderful health benefit on top of it. So that's number one. David, do you want to add anything to that?
Go ahead and keep going. I might chime in at the end, but you're doing great. Awesome.
This concept of shopping local, we touched on this a little bit with that question about the network. And that, again, we're removing the waste. Why is that, the cash pay price for an MRI at a local hospital in St. Louis is the best price compared to United, Anthem, Cigna, Aetna, and any other PPO out there? And we can see this data now because of the recent legislation that was passed. So hospitals are posting these prices. Why is the buying power of one person getting the best deal compared to the buying power of these huge insurance companies? So allowing this concept of shopping local just keeps our dollars in our community. The healthcare workers, the nurses, the doctors, the admin staff, these are all people that we work and live with. They're in our community. We can keep our dollars local. We can cut out a lot of fat and waste that plagues the system, and everyone wins, right? The hospital systems win, the doctors win, the patients win, And, having these local contracts and these relationships allows for incredible access to high quality healthcare. This third piece for us is really important because as we're kind of going along this journey and we're tinkering with building these types of plans, we weren't really delineating between where we had great contracts and great relationships with care teams. We just had, here's your plan, here's your deductible, here's your copay. Behavior change is very hard. We know this. The movement towards consumer-driven health plan has largely failed because it's very hard, if not impossible, to be a good consumer of healthcare. Nobody publishes their prices at the consumer level. Nobody publishes quality data at the consumer level. It's very hard to be a good consumer. And who can come up with a $4,000 deductible anyway, right? So this idea of eliminating deductibles does a few things. One, it's easy. People understand it. Again, most people don't know what deductible or coinsurance is. We just get rid of it. This also steers and drives the behavior outcomes that we want. We know we're getting great unit cost of care in certain areas, certain hospitals, certain health systems, certain doctors. Those are the free options. That's where we've eliminated deductible. So we've taken the thinking out of it and built it right into the plan design. It's very simple. It's very linear and it works. And this is also, the human element, right? Who ever thought that they can have no deductible health insurance without paying an arm and a leg for it? And so it's kind of that surprise factor, the wow factor. We know that if we focus on the consumer, on the patient, then everything else is going to work itself out. Because if we make them the focal point and make their experience awesome, and make this plan work on day one, because there is going to be a lot of fear and trepidation about the change in general, then we're all going to win. And that leads into this advocacy component. Did you want to say something, Gray?
I'm sorry. I just wanted to say, as a member, as a consumer, I absolutely 100% agree. And I think it's obvious, but a lot of us are afraid to go to the hospital to go take care of a very easy checkup or whatever it may be, because we are afraid to be using money out of our deductible, right? And so if we can get past that and then use the doctor the way we're supposed to, then all of a sudden we have a healthier community, right? So anyway, I just want to plug that.
No, you're right. I mean, we talk about healthcare is expensive. Deductibles are expensive, right?
Yes.
Yes. And it's led to far more worse outcomes than what was ever designed to do. But worst off, we sold it as a way to bend the cost curve, and it hasn't done that. Oh, so it's like, let's just get rid of them. They don't make sense. So this advocacy component, really being that shepherd, that guide, because navigating healthcare is complicated, it's emotional, it's expensive. How do you get good information? So providing that level of care is really what enables all of this to work really, really well. Awesome. So whether it's, hey, I just need a new ID card, or I need help finding a doctor that's in the network, or I need help understanding this bill, or I have a surgery, I don't know where to go. All of that gets funneled right to our advocacy team. Just make it really simple for employees and spouses and members to reach out for that type of help. The last two here is really about alignment and improvement over time. In a self-funded plan, the beauty, again, having the control and the flexibility allows us to make little pivots throughout the year. You can't do this in a traditional plan because those contracts aren't owned by you. So if we need to expand the network with contracting with more providers, or if we need to override a medication, or have a medication that was pre-approved in the last plan, overridden on day one, we can do these things in the self-funded plan. So it's this, once we have the data and we're getting the feedback on what's important to the plan members, we can start making improvements over time. The last piece is just about compensation alignment, and we're fee-based, fee only when it comes to the medical plan. So our compensation is not tied to the cost of the insurance, not tied to the cost of stop loss. We're paid by our clients directly and exclusively. No one else in the ecosystem is compensating us for the work we're doing. And that's also how we align the solution partners that are part of the plan as well. So it's all very transparent. And we want to align for the outcome, which is great healthcare for less.
Awesome.
Yeah, and let me just chime in on that point, because it's incredibly important. When we think about the toxic impact of these high deductible plans, it's real. One of Adam's colleagues, Justin Leader, shared a story about his aunt. Because of these ridiculous super high deductibles, people avoid the system. They know that basically entering the system likely means bankruptcy. In the case of his aunt, she kept her issues to herself because she was concerned she was going to ruin her family financially. But by the time she was admitted to the hospital, hemorrhaging from stage 4 cancer, for a very standard cancer that if she'd been able to get in easily, we have all these things to put up barriers for the low cost parts of healthcare, like going to a primary care doc. And then, I talked earlier about preventable medical mistakes being the 3rd leading cause of death. Where you send people really matters. And so it creates this dynamic where you've used up your deductible and then like, oh, I don't care where I go. And I don't care if it costs $1 million versus $100,000 or whatever. You actually should care. And the paradox is usually the best outcomes are the least costly. And so that's really important. And I saw a question in the chat, and I'll just, Adam mentioned this local acrostic that's on the back cover of my last book, this Relocalizing Health. And he covered most of it, but I'll just emphasize the first one, which is learn how to be liberated from status quo mindset, right? Nothing happens. Like, that's the key thing. When mindset shift happens, when you no longer believe what the healthcare system would like you to believe, that solving healthcare is like trying to solve Middle East peace. If you believe that, they're right. You're right. If you don't believe that, which is not true, then the rest of it's pretty straightforward. And so you have that mindset shift. And one piece of that is educating employees. The biggest chapter in the book I just waved on the screen, Relocalizing Health, is on change management. And you do need to be thoughtful, even if you have an incredibly well-designed plan, even though 4 of the 5 steps in that local acrostic of how to transform your plan are invisible to the member or clearly a positive, it's still change. And you need to be thoughtful on that. The most watched video from any of our summits has been when one of Adam's colleagues, Bryce Heinbaugh, went through his member education and took a group of working class individuals who are not healthcare wonks from entering the meeting to, yay, this is another one of these, pay more, get less open enrollment meetings, to they started to understand why they hadn't had a net wage increase in over 20 years. You can approach that very straightforward. If people want to reach out to me, I'm happy to share a link to that video. It's a really good example of what Adam and his colleagues do to educate the member. You really do need to do that well, because even though it might be way better, it's still change. And so you have to be very thoughtful on member education, as well as, convincing the C-suite that the change makes sense too.
I love the talk about member education, Dave. And I feel like that could also be another episode for us here at Fireside Chat. Thanks, Dave.
Yeah.
Okay, so let's bump over to Heath Potter. I know Heath has been nagging me. He's like, Gray, I've got some questions. When are we going to go to me? We've got about 15 minutes left, folks. So Heath, what you got? What's being pushed out into the Q&A world?
Hey, yeah, my very important role I play in this whole format. So there's a couple questions that come in. One of the early ones was, how do you get direct contracts? And I'll hand that over to Adam and Dave. But first, I'll chime in on 6 Degrees part. Is part of our MediBridge RVP solution does include contracting. So that is something that we do, but oftentimes our channel partners and advisors get involved in that themselves as well. So Adam?
Heath, I think you nailed it. I mean, I think for folks that are getting into this for the first time, the direct contracting component of this, rely on these partners. They have whole teams and operations built to handle this type of work, and they have data now. There is now a wealth of data that is publicly available. I know Marilyn Bartlett with her work in NASHP, you guys have to look up this hospital cost tool because it's just fabulous. the kind of data you can get now at the hospital level of reimbursement rates and break-even levels and how much debt they're, bad debt they're writing off and so forth. But having that data is critical to having these conversations, but it's also finding the right folks at the hospital level, the health system level to engage, because it's a value conversation, it's a value equation, and not everyone gets it. And so it's not a light switch. It is a constant process, and it evolves over time as well. So, Dave, anything to add to that?
Yeah, I would just say, it depends on your experience level, right? If you're just stepping into self-funding for the first time, direct contracting is probably not where you're going to start. When I mentioned 4 of the 5 steps, Adam actually went through a bunch of the second one, which is optimized plan infrastructure. We've seen $1,000 per employee per year of savings just in kind of doing spring cleaning on how you're working with your broker advisor, how you're working with your TPA and all the other players. And so if you're more experienced, yes, there's tremendous opportunity. The biggest bang for the buck is in leaving behind the PPO networks, but step by step, right? And work with the right people. I wouldn't go from having always, pitched carrier controlled plans to, going off the 10-meter platform dive and doing a double flip and a twist, right? There's really thoughtfulness you want to have as you get into the network side of stuff.
Yeah, there's such low-hanging fruit on the pharmacy side, on, as Dave said, the foundational infrastructure of the plan, the contracts that drive the plan document. There's so much additional, you can do so much lower investment work on the front end without the heavy lift of direct contracting, and you're going to see tremendous results.
Gotcha.
All right. So this next one, I'm actually wondering if Dave wrote this question himself, but throw it your direction. And the question is, as you line up all the vendors and components, how do you deal with some of the mini agreements having to be signed by the employer? We ran into a situation where we had about 8 agreements needed signed, all with different formats, different requirements, rate increases, termination agreements, et cetera, et cetera. So how do you deal with that?
Yeah, no, that's a great question. And one role we're trying to play in this is shifting the industry from being this massive but cottage industry where everything is bespoke and one-off. And so we know there are excellent individual solutions out there. And so we go through a process, which 6 Degrees has gone through with us, where it's, they could characterize it, but I'd call it an onerous but fair process, where we go through and say, hey, rather than have 42 different versions of these contracts, why don't we have standardized deal terms? Why don't we have standardized data sharing agreements? Why don't we have standardized service level agreements? Let's not do what the industry does, where everybody blames everybody else when there's an issue. That's one of the most disappointing things about a lot of the big incumbents, is they blame everybody else and don't step up. And so we have certain things that then make it plug and play, right? And you're actually working as a team. It's not just a pair of, or a bunch of individual NBA all-stars. They're actually great team players working together. And a big piece of that is the contracting piece and kind of unifying and standardizing that. That's probably the biggest single investment that we've made is in lawyers and other agreements, because it's such a key thing. The analogy I use is, if U.S. healthcare was a nation, it would be the 4th largest economy in the world. We call it Healthcareistan. And in Healthcareistan, we waste $1.5 trillion. That's well documented by the National Academy of Medicine and PwC. How is it possible we could waste $1.5 trillion? It's all codified in the laws of the land of this Healthcareistan. That's actually what enables all that waste. And so we realize we have to really dig in on that. And fortunately, there's great organizations that get it and want to move the industry forward. And so that's a big piece of what we work on.
Yeah, that's what we're doing here. Absolutely. Heath, I think we have time for one more question. We are going to wrap things up in a few minutes. What do you got for us?
I'll throw this one to Adam. When a deductible is eliminated, doesn't the number of claims go up?
We get that question on occasion, you know, and it's an interesting question. And I think it rests on the premise that folks are putting off healthcare services or delaying healthcare services because they can't afford it. And now that they have, you know, no financial component related to their care, they're just going to go, you know, crazy on their new knees and hips and everything else. We might see a little bit of that, but frankly, where we see the increases in utilization is primary care goes up, mental health care goes up, PT and chiropractic care goes up. And those are the areas that we want to see the utilization happening because we've controlled the cost. It's not a huge expense for a self-funded plan, but it's that preventive investment that we know is going to pay off long-term. There's also things like prior authorization and other things that are going to prevent someone from just going to get a knee replacement on a plan like this. But the reality is there really isn't this massive pent-up demand that drives the plan to go to basically explode. On the claim side, you know, you got to think that our membership, right, the folks that we're serving are primarily working Americans, and if they're taking time off to get an elective procedure, they're losing hours at work and they're not getting paid. And so, you know, putting this all in the context is the short answer is we just don't really see that happening.
Yeah, I mean, no offense to doctors, but most people, like, the highlight of their life isn't going to the doctor.
Right.
And if it is, they may have a mental health issue, right, that needs to get addressed. And one of the ways you don't see the claims go up related to what Adam was talking about is when you have a budgetable item like primary care that is a fixed budgetable item, there is no need for claims. It's just an annual per employer, per member, per month arrangement. And when you put in, it's not a state secret that there's no well-functioning healthcare system in the world not built on proper primary care. And in a fully actualized primary care setting, 90% of the issues people enter the healthcare system for can be fully addressed in primary care. Sadly, that's not what most Americans have experienced in the last 20 years, but it's a very straightforward thing to put in the vast majority of the situations. And then, you know, that's how you reduce 50% of the ER visits that are actually not an emergency, 50% of surgeries that are actually not medically indicated, and there's not evidence that they're effective. That's how you don't get people addicted to opioids, because the number one driver of disability and opioid prescriptions is lower back pain, and there's no evidence that opioids are effective there. So these things, again, it's pretty common sense stuff once you actually take a step back. And we've just seen time and again, yes, you'll see some cases where before they shift to a direct primary care model, primary care or PT visits may go up. But guess what? Those are two of the most effective evidence-based things in the entire healthcare system. And so we're happy to pay small dollars to avoid the massive dollar things.
I love the conversation about direct primary care. We've talked about that a little bit in past episodes too, and it's certainly something that's on my radar for future episodes. So thank you, Dave. And thank you, Adam, for bringing that to the table. Folks, we do need to wrap things up. I think that a lot of our guests probably need to take off. So I want to make sure that you know who to talk to if you've got some follow-up questions. Dave Chase, again, he's the co-founder of Health Rosetta. He had posted in the chat function, Dave, you can do it again if you'd like, how to access his book. Like I said, I've read it a few times, and Dave's got some really great ideas. He's got some of his own case studies in there, and he really gets into the nuts and bolts of how to kind of embrace what we're talking about today. Adam Berkowitz, first time here. I hope I see you again. Adam, would you like to come back and see us?
Absolutely.
Loaded question. Founder and president of Simpara, based out of St. Louis, Missouri. Adam's, his email is here too, Adam at SimparaHR.com, and then Dave at healthrosetta.org. As we finish up, folks, I want to thank everybody for showing up today. We will be doing another one of these shows next month. Come visit our website. Take a look at what we're up to. The free download of Dave's book can be found there as well. But yeah, come take a look at what we're doing. All of our past episodes are also on that webinar page on our homepage. Stanley Morkall says, thank you. We are so glad you joined us today, Stanley. And everybody who's here, we really appreciate the dialogue, trying to get behind how to transform healthcare, how to create outcomes that benefit everybody. I know at the end there, we got into this piece about eliminating deductibles so that people actually use their healthcare. We got happy employees, happy, healthy employees. Can you beat that? Thanks, Adam. Thanks, Dave. Thanks, Heath.
Thank you.
You're welcome. Enjoyed it.
Great. We'll see you next time.
Cheers.
Take care, everybody.
Bye, everyone.